Thank you, Amy, for the introduction and the chance to participate in today's meeting. As Amy mentioned, I'm going to stitch together two different sets of analyses that we initially conducted without really thinking about how they relate to one another. And so I'm, in preparing for the talk, tried to think more about where are the common threads and how do they inform one another. And I'll try and highlight those as I go. Just begin with disclosures and acknowledgements. This work really, it has two components. One was supported by a small grant from the Department of Veterans Affairs, and the other was conducted as part of the VA's ongoing evaluation of suicide and suicide prevention. And these are my opinions, not those of the VA. And this has really been a collaborative set of analyses, and really it's a collaborative body of work, the foundations of which were laid by Marcia Wallenstein, Fred Blow, and others. And for these particular results, I want to make sure that I acknowledge Amy Bonnert. We borrowed heavily from her work on unintentional overdose when we looked at suicide, and I'll describe that in a bit. Allison Lynn, who is here and is an addiction fellow with our group, and really has taken the lead in helping us interpret and think about the analyses of the national VA OSI rollout. And Dara Gnozzi, who is here too, who's been our analyst on this work and really been crucial in thinking about how to go about approaching these analyses. So my overall goal today is to highlight the ways in which national data from the VA and more broadly national health system data can inform our understanding of some of the risks associated with opioids, as well as the impact of strategies that try to mitigate those risks. So we've already heard that to begin with the presentation from Group Health, and I'm going to try and continue that discussion and talk about some of the things the VA has been doing. Specifically, the two studies are to look at the ways in which opioid dose relates to suicide risk, and then transition to describing results from the VA's OSI rollout. And this will be the initiative that Minneapolis took and ran with. We're going to describe how did that go nationally, and did that lead to broader changes in prescribing. So to dive right in with the analyses related to suicide risk, this work flowed out of work that we'd been doing for a while related to chronic pain and suicide. So there have been a number of studies documenting the high prevalence of suicidal thoughts and behaviors in people who are treated in chronic pain treatment settings. There have been a handful of national studies that have looked at the cross-sectional relationship between experiencing pain, self-reported pain, and suicidal thoughts and behaviors. And then there have been around 6 studies that have actually looked at suicide mortality. We've conducted 2 of those in the VA, the first of which looked at self-reported pain ratings as predictors of risk of suicide. And in that study we found that the higher you rated your pain, the more likely you were to die by suicide in the ensuing 3 or 4 years, and that relationship held after controlling for other co-occurring psychopathology and medical comorbidity. And then more recently, we looked at specific pain conditions and the extent to which being diagnosed with chronic low back pain, migraine, and other pain conditions predicted likelihood of suicide. And again, people with a large number of pain conditions were at greater risk for suicide. And I'd like to say that the opioid-related analyses came out of kind of a scientific rationale, but they were more based on anecdotal experiences. I made the potential mistake of reading some of the popular press that came out of our studies of pain and suicide and the discussion boards that go along with those. And a common comment you would see in those discussion boards were when we said, pain was associated with a greater risk of suicide, and I'm paraphrasing here, they would say, no kidding, having pain is not pleasant, and it makes me want to hurt myself. And you know what really makes me want to kill myself is the fact that my prescriber is trying to take my opioids away. And there's this perception among the patient community that opioids might have some sort of protective effect. Again, in the domain of anecdotes, there is also an echo of that among treatment providers. This is a opinion piece in 2014 from the president of the American Academy of Pain Medicine. And here she provides a case study and essentially saying that, asking the question, have we gone too far in trying to curb our use of opioids, and making the case that scaling back on opioids may be causing patients to become hopeless and take their own lives. So that's the argument that opioids may have a protective effect as it relates to suicide. On the other end of the spectrum, we know from a number of years of suicide research that access to lethal means matters as a risk factor for suicide. So there are a number of ecological studies. Some of the best known were conducted in the UK when they switched from coal gas to natural gas in their ovens. You may have heard the phrase head in the oven, where someone uses gases to commit suicides. When they made that switch in the UK, they found that the rates of suicide by that method reduced substantially, which I guess isn't all that surprising. It became harder to do. But there was also not a corresponding increase in suicide by other methods. So the message there, and it's been kind of played out in terms of other risk factors, is that when you make it harder to access a method to kill, for someone to kill themselves, they're less likely to use that method, and they're less likely to die overall. So this would argue that if you reduced access to opioids, you might have a lower risk of suicide. And we kind of wanted to play these two potential hypotheses against one another in the VA data. So for this study, we borrowed liberally from Amy Bonnert's JAMA paper looking at unintentional overdose. And I'll kind of move quickly through the methods. Essentially, we used the exact same approach and traded out suicide as the outcome instead of unintentional overdose. For this, we looked at individuals who, the cases were individuals who died by suicide who used VA during a certain period, and we looked at their suicide risk over the ensuing 5 years. And both cases and controls were restricted to everyone with chronic pain who were in those two groups and treated with an opioid. And we also tried to exclude people who were receiving palliative care from our analyses. And we had a large sample size for this type of analysis. We were looking at suicide, overall risk of suicide, or overall suicide mortality as the primary outcome in this study. And as a secondary outcome, we wanted to look specifically at intentional overdose. We figured if we're going to see a signal for these effects, we'll see it most in the domain of overdose. Just to orient you to suicide in the VA, the vast majority of suicides in the VA occur by firearm. So unintentional overdose occurs about 15 to 20% of the time in the VA. And we wanted to hone in on that rarer form of suicide to see if the effects were observable there. And then in terms of our models, we were looking at maximum prescribed morphine equivalent daily dose. And what we tried to do is add up all the different opioids someone was receiving and look at the extent to which that dose related to their suicide risk. So in terms of results, it's probably easiest to look at the middle column there, which is the suicide by any mechanism. And what you see is that with the lower dose prescribing as a comparison, as opioid dose goes up, so does the risk of suicide. So you've seen the graphs a lot today around unintentional overdose. These findings parallel what was seen there. Somewhat interestingly, though, when we honed in on intentional overdose, you see that the hazard ratios there are essentially the same as what you see for overall suicide risk. And which I'll talk maybe about what might be going on there, but it was certainly curious to us. It didn't seem like it fit neatly into the category of access to lethal means as the easiest explanation for the findings. And these analyses controlled for a number of patient factors that might also be linked to suicide risk. A couple of additional slides that were supplementary analyses we conducted here. One of the things that we wanted to try and account for is the fact that obviously people receiving higher doses of opioids are getting them for a reason. And we were curious about whether increases in dosage of other pain medications were related to that they had a similar association with suicide risk. So we used acetaminophen here, tried to break it down into low, medium, and high categories. And there was essentially no effect where you see an association between higher acetaminophen dose and risk of suicide. The red line there is just a graphic representation of the numbers I already presented, with the opioids going up over time. This last slide for this set of analyses maps on our findings for suicide on top of the previously published findings for unintentional overdose. And my point in showing you this slide is that, yes, we're seeing an increase in suicide risk with hazard ratios around 2 for the higher risk group, but the magnitude of association is clearly much less than what we're seeing for unintentional overdose. So I think that helps put the findings into context and maybe in terms of their public health importance. So to wrap up this set of studies, first of all, it's easy to look at results like this and conclude that the findings have something to do with the medication itself, but we really can't conclude that. This is an observational study, and we're just able to say on average to what extent is someone who is in possession of these medications at greater risk. We can't say the medications cause that greater risk. So there are any number of alternative explanations, including the fact that patients are different who get different doses of opioids. And there's also the fact that treatment itself may be meaningful. So higher doses of opioids, especially as you get on the far end of the continuum to high-dose opioid prescribing, could be a marker for worse care, and that in of itself could be associated with greater risk. All that said, we at the very least did not see a signal for a potential protective effect of opioids on risk of suicide. So Erin mentioned this in her slides, and I think we've heard it from clinicians. There is this fear that if someone's going to change opioid prescribing or go lower in terms of dosage, that patients will end up taking their own lives at higher numbers. And at least on average, we aren't seeing evidence of that effect, although obviously there are any number of case examples where that could happen. And then just to restate, there's the increased dose of opioid associated with increased risk of suicide. This doesn't seem to be limited to intentional overdose. So that begs the question, what's going on here? And I think one potential explanation is the fact that taking higher dosages of opioids does impair judgment for a lot of individuals. And so there's the chance that for someone who's struggling with suicidal thoughts, struggling with depression, to be somewhat cognitively impaired as they go higher in their opioid dose, they may actually be more likely to engage in suicidal behaviors of all sorts, not just intentional overdose. And again, putting this in context, I think, we talk about the epidemic of unintentional overdose. Suicide, it may fit into the story a little bit, but it's not at the magnitude we've seen. So now comes the transition in my slides where we talk about the other study. So given there's an association between opioids and adverse outcomes of all sorts, what can be done about it? And for these analyses, what we wanted to do was examine how the OSI related to prescribing, changes in prescribing practices over time. I'm going to skip over the description of the OSI. Erin already provided this, but this basically involved providing detailed information to a point person at individual VA facilities, and the goal was that they would use that information to encourage prescribers to change their prescribing practices. There were a number of targets of the OSI. We wanted to hone in on very high dose opioid prescribing and co-use of opioids and sedatives as our main outcome. And we're essentially looking at how all this changes over time. We looked at this at the facility level, and we wanted to look in the 12 months prior to the OSI, right around the time of the OSI rollout, and then the 12 months following it. So the first set of results here, this is for prescribing at the 100 milligram level or higher. And what you see is that the rate of prescribing among all patients who received an outpatient prescription was around 9.8 at the outset, and it dropped to closing in on 9% as over time. And here we saw that there's an overall decreasing slope in the amount of prescribing, that there was actually a slight uptick around the time of the OSI, and despite that, you see that the slope actually increases over time with greater reductions in prescribing during the 12-month period post-OSI relative to the period of time, the 12 months prior to the OSI. This is for, this is a similar slide, just looking at the very high prescribing, greater than 200 milligrams. Here you'll see it's much rarer, around the 3.5% range to start with. It drops down to around 3% at the end of the observation period. And again, what you see is the slope's going down, it flattens out or slightly blips up, and then continues to decrease over the latter 12 months. And again, that pace accelerates a little bit in the year post-OSI. For the co-prescribing of benzodiazepines and opioids, you'll see that that is in fact quite common in the VA. And it starts out at around 25 during our beginning of the observation, around 23 at the beginning of the observation period, and drops down to around 21.5%. And here the rate was going down pre-OSI, and it actually flattens out and technically bumps up slightly in the year post-OSI. But for the most part, that post-OSI period is pretty flat. So one final data slide for this set of analyses, and what we're trying to do here is highlight the degree of variability in change pre to post OSI. So you heard about, again, the Minneapolis approach, which I think is often presented as the exemplar for an ideal response to the OSI, although you guys sound like maybe on your end you still had your concerns. For the most part, there were positive changes there. But that certainly wasn't universal as the health system tried to roll this out across the country. And what you see is that especially if you look at the 200 milligram group, there is a general sense that people are decreasing more than increasing, but you still have a number of facilities that are either holding steady or increasing in terms of their use of opioids at that level. The results around 100 milligrams are slightly more promising, but again, there's a lot of spread. So in terms of take-home messages here, there's a high use of higher dosage of opioids is decreasing in the VA. We've talked about this kind of, especially in the initial talk, this kind of plateau in terms of opioid prescribing in this country, and that is for the most part present in the VA as well, and we're now on the downslope of prescribing. And the OSI rollout, at least in this way, was associated with a somewhat significant acceleration in the slope of decreasing prescribing, especially in the higher dose prescribing. That said, we did not see any effects relative to the opioid and benzo co-prescribing, which is quite common to begin with and seems to be decreasing ever so slightly, but not in a way that seems to coincide with the OSI. This could reflect the fact that clinically patients are very hard to address. You're in a sense talking about two different problems at once, as opposed to just pain. And it also, in a lot of the materials we'd get about the OSI, sometimes the co-prescribing topic, I think, got underemphasized, and the real focus came onto the high-dose prescribing. I want to make sure I note here that these are observational data. We're really looking at ecological trends, so a lot of things happened around the time of the OSI rollout, and they may have had very little to do with the OSI, and so we need more years of data, and we need other designs to make strong conclusions about the extent to which the OSI per se caused changes. But that said, there's clearly a lot of variability in the ways in which people use opioids around this country and the ways in which that might have changed around the rollout of the OSI. And I think it highlights the potential for future work that can look at how could you use strategies like they used in Minneapolis, like are being developed other places or used in group health, and get that out to more places where they could benefit and hopefully change practices over time. So just a final slide, and to tie the two different studies together. So to begin with, I think there is a real need to quantify and understand the potential consequences of this huge increase in opioid prescribing we've seen in this country. We started with and have remained focused on unintentional overdose for obvious reasons, but there are any number of other adverse outcomes from drug driving, crime, heroin initiation that we also should consider. And I think suicide might be one of those outcomes we want to add to the list to monitor and try to more closely tie to opioids. And then the health systems clearly played a role in access to opioids and in this general epidemic. And as a result, they need to play a role in somehow trying to address it. So there needs to be a greater emphasis on system-wide approaches to reduce the use of opioids. And hopefully these can be done in a way that use national mandates like the OSI, but then partner with local individuals who have the passion and the follow-through to actually implement them in effective ways and hopefully change opioid prescribing. Thank you. Are there any questions? Yeah.
Thoughts on what the differences were between the VA systems that saw increases and compared to those that saw decreases after implementation of the OSI? Have we looked at that?
We haven't looked at that. So the question is whether there were differences between the facilities that increased or decreased or held steady. And that is the next stage. So that, I think, those are aims 2 and 3 of our grant. So we're moving on to that point, but interested in it. I think the VA has a big push towards implementation science and those types of methods. I think the challenge is that there are facilities in the VA who tend to do a good job at lots of things, and there are facilities in the VA that tend to be left behind. And often that's true across any number of initiatives. And my guess would be that you'd see a similar pattern in terms of opioid prescribing. So you kind of get the same usual suspects that seem to be associated with not quite being on the cutting edge of what the trends are, but it's then harder to find that individual advocate in those facilities to start changing things. Yeah, Erin.
Just with the opioid and benzodiazepine combination, we know this is a hazardous combination for a variety of reasons, but so a couple questions. One is that at least my impression locally is that in my experience, it's usually psychiatry prescribing the benzodiazepine and primary care prescribing the opioid. And so sometimes there's a little bit of a, if they're not on the same page, you're not going to fix the problem. And so I'm curious if that's a national pattern or just a local experience. And then the other question is whether you looked at if there was a decrease in co-prescribing, which one came down more often?
Those are both really good questions. I mean, my short answer is we haven't looked at either of those issues. Looking at who wrote the prescription is somewhat more challenging, and so I'm not all that optimistic that we'll be able to get to hone in on that very well. But the question about the timing, did the opioid drop precede benzodiazepines or vice versa? It's an excellent question. I don't know. My guess is that there's not a lot of emphasis on changing benzodiazepine prescribing right now. And there are anecdotally, some clinicians who feel more comfortable providing that as a way to placate patients who are concerned about the opioid dose changing. So I wouldn't be surprised if that's holding steady or maybe spiking slightly.
Yeah, there seems to be, well, there is a lot of pressure in the acute care setting to achieve these always scores on the HCAP surveys. And is there any dialogue between the CDC and this OSI initiative with CMS on looking at that? Because that really does drive practice. There's a, you know, reimbursement is tied to that. So you have to get those surveys with those always responses.
So I'm going to actually hand off to our CDC experts here to answer that question.
We are in active conversations with CMS about those, changing those questions because we have sensitivity to that exact issue. In fact, those conversations have happened at the CDC director level within the last 8 weeks. So,
Thank you.
I was curious in your data on the patients with chronic pain who did commit suicide. Did you happen to look at what percentage of these patients committed suicide via their prescribed medications as opposed to other methods of suicide?
So I'm trying to think if we definitely looked at the percent who had intentional overdose and were, as I mentioned, that didn't really look that different from what we'd expect for the overall VA patient population. We didn't hone in on specific medications to look at whether that was attributable to prescribed medications versus other forms of unintentional overdose. So that's a good question. Yeah.
Thanks, everybody. We're looking forward to our afternoon sessions. Thanks, Mark, for closing us out.